For today's video, I will be showing you the steps on how to perform respiratory examination, both posterior and anterior chest. The first thing you do when entering the examination room is to greet the patient, verify the patient, introduce yourself, and explain to the patient the procedure you will be doing. Good morning, I'm Dr. Barolo. Can I confirm your name and your date of birth, please?
Edward Barolo, January 5, 1965.
Okay, nice to meet you. Today, I will be performing respiratory examination, which will only involve me inspecting you from the end of the bed and then moving in closer, listening to your chest with a stethoscope. Will that be okay with you?
Okay.
If you could just take off your clothes for me and we'll start examining your posterior chest. Can you cross your arms for me and put your hands on the opposite shoulders? Okay, that's it. And then breathe normally for me.
Now, examine the posterior thorax beginning with inspection.
I'm trying to look for any symmetry and deformities, as well as abnormal muscle retraction and impaired respiratory movements on both sides of your chest. Okay, tell me if this hurts anywhere.
Palpate the chest wall to locate any areas of pain or tenderness, or to assess any lesions or abnormalities you may have found during inspection.
Now I'm going to assess your chest expansion.
Place your thumbs at about the level of the 10th ribs with your fingers loosely grasping and parallel to the lateral thorax.
Can you please inhale and exhale deeply for me?
Ask the patient to inhale and exhale deeply and fully while you watch the diversions of your thumbs and feel for the range and symmetry of movement.
Now I'm going to palpate for tactile fremitus. Okay, I'm going to put my hand on your chest. Is that okay with you?
Okay.
And I want you to say 99 every time I touch you, okay?
Okay.
Feel for the vibration of tactile fremitus using the bony part of the palm at the base of the fingers, while the patient continue repeating the words 99. Identify areas of increase, decrease, or absent fremitus.
I will percuss your chest so that I can listen to the intensity, pitch, and duration of the percussion notes.
Moving down from thorax and going from side to side is demonstrated in the ladder pattern. Remember that only the posterior surface of your pleximeter finger should be in contact with the chest wall, and with a relaxed and fluid wrist motion as you make 2 strikes with your flexor finger. Decide on what kind of notes you were hearing. Normal lungs are resonant.
Okay, now if it's alright, I'm gonna put some marks on your back. Can you breathe all the way out and hold it for me, please?
Then percuss downwards from above expected level of diaphragmatic dullness until dullness is definitely heard.
Now I'm marking the full expiration.
Repeat this process on the other side.
Okay, now can you please take a deep breath again and hold it for me, please?
Percuss downwards at the level of dullness and full inspiration and mark it. Then, measure the distance between expiratory and inspiratory levels of dullness. Distance is normally 5 to 6 centimeters.
Can you cough once or twice for me? This is to clear airway mucus that can produce unimportant sounds during examination. What I want you to do is to take 1 breath in through your mouth and 1 out through your mouth, okay?
Okay.
Auscultation allows evaluation of breath sounds, which can diminished or increased, for instance. Auscultation may also reveal other abnormal findings such as crackles or pleural fiction rub. Breath sounds heard over pulmonary tissue are vesicular.
When you feel my stethoscope on your back, I'd like you to say E and kind of prolong it, okay?
Okay. E.
Egophony is another sign of consolidation. When a patient verbalizes, The sound takes on a nasal quality and an E sounds like an A. This is tested by asking the patient to say E while listening with a stethoscope.
When you feel a stethoscope on your back, I would like you to repeat the words 99.
99. 99. 99.
Bronchophony is the sound that a spoken voice makes when you listen over a large airways. Words are louder and clearer than when listening over peripheral areas. When bronchophony is present in an area that is not over one of the main bronchi, it suggests that there is an underlying consolidation.
When you feel my stethoscope on your back, I would like you to whisper 99.
Whispered pectoriloquy is an exaggerated form of bronchophony. When there is consolidation of lung tissue, even a whispered sound may be louder and easily heard while listening with a stethoscope.
Okay, let's proceed to the anterior chest. I want you to relax and breathe normally as I inspect your anterior chest. Okay, tell me if this hurts anywhere. Now, I'm gonna assess the expansion of your chest.
Place your thumb along each costal margin and your hands along the lateral rib cage.
Can you please inhale and exhale deeply for me?
Ask the patient to inhale and exhale deeply and fully while you watch the diversions of your thumbs and feel for the range and symmetry of movement.
Now I'm going to palpate for tactile fremitus. I'm gonna palpate your chest again, and I want you to say 99 every time I touch you, okay?
99. 99.
Now I'm gonna percuss your chest, and by doing this, I'm gonna place my finger on various spots, and I'm gonna tap my finger, setting up sounds that I can hear. And what that tells me is if your lung tissue is normal, or is there any abnormal growth in your lungs. I'm gonna hear a certain sound called resonance over your lung tissue, and when I get over your heart, I'm gonna hear the sound called dullness. So now I'm gonna start.
Remember that only the posterior surface of your pleximeter finger should be in contact with the chest wall, and with a relaxed and fluid wrist motion as you make 2 strikes with your flexor finger.
Now I'm gonna listen to your chest. If you could just take a deep breath in and out for me.
Listen to the chest anteriorly and laterally as the patient breathes with mouth open and somewhat more deeply than normal.
That completes my examination. Thank you so much. You're very welcome to get dressed now.
Thank you, Doc.